A very good evening to everyone, and welcome to the webinar on sleep apnea. I'm Dr. Syed Raza, consultant cardiologist at Awali Hospital in Bahrain, and I'm your host and coordinator for this evening's meeting. Sleep apnea is a common medical condition, yet it is unrecognized or under-recognized, sometimes misdiagnosed, and very often never diagnosed. However, raising its awareness amongst public and healthcare professionals is vital, as patients suffer in silence for years together with the impact of sleep apnea and its health consequences. In my own clinical practice, I've seen a number of patients suffer, and I've seen their misery, and they suffer not for months, but for years together. And what a life-changing experience they have once they have been diagnosed adequately and they have been managed appropriately. Now, before I start the meeting formally, I would like to go through some housekeeping points. First and foremost, may I request you all to mute yourselves or mute your microphones. If you have any question, then please click the raise hand icon, or you can put your question in the chat box. When you are asked to speak, then please unmute yourself and then you can start to speak. But at the same time, please keep the background noise to nil or minimum. For any technical reasons, if you are signed out, then please don't panic, don't worry, you will be signed in soon again. We are 4 speakers here tonight, including myself, and each have been advised to speak for about 20 minutes. Following which we will have a question answer session for about 10 to 15 minutes. So if you have any question or questions, then please type in the chat box. Alternatively, you may also be invited to unmute yourself, then you can ask your question. I am honored this evening to be joined by 3 speakers, each of them from different specialty. And this proves that sleep apnea management requires multidisciplinary approach. Without further ado, let me start with to invite my hospital and departmental colleague, Mirjana Devenica. Dr. Mirjana is a pulmonologist with 15 years of experience in sleep medicine and sleep disordered breathing. Dr. Mirjana has completed her PhD thesis in sleep medicine. She is a former head of the Department of Sleep Medicine at the University Hospital in Serbia. She has extensive experience in clinical trials in sleep and respiratory medicine. She is author and co-author of many peer-reviewed articles in sleep medicine. She is also editor and reviewer of many journals in the field of respiratory medicine. Dr. Mirjana is going to speak on sleep apnea, overview, and role of respiratory physician in sleep apnea. Whenever you are ready, welcome Dr. Mirjana, and the screen is yours.
Thank you, Dr. Syed, for such a nice introduction. Thank you all of you that are attending of this meeting. I hope you will enjoy. So I'm going to talk about sleep apnea from respiratory review. So I want to, at the beginning, just to introduce that sleep disordered breathing is just one small segment of sleep medicine that include a range of diseases that occurs due to increased resistance in upper respiratory tract, and they reflect during the sleep. Sleep disordered breathing are divided in few entities. It's obstructive sleep apnea syndrome, central sleep apnea syndrome. Those are synonyms. And central alveolar hypoventilation syndrome, primary snoring, infant sleep apnea, and congenital central hypoventilation syndrome. I just wanted to clarify the difference between obstructive sleep apnea, hypopnea syndrome, and just obstructive sleep apnea, hypopnea, or OSA. Obstructive sleep apnea, hypopnea, or obstructive sleep apnea, it's the same terms. Only if we have a syndrome in a name, that means that we have excessive daytime sleepiness. So that is the difference. The prevalence of sleep disorder breathing are about 20% of the general population and affecting up to 24% of men and 9% of women in the middle-aged population. And just OSAS occurs in 2 to 26% of general population, depending on gender, age, and body mass index. So what happens during the sleep apnea, during the night? So patient fell asleep, and in upper airway muscle activity, there is a reduction in upper airway muscle activities, and that leads to upper airway obstructions, and that cause hypoxia, hypercapnia, and acidosis. And as a protection, we have arousal. And after arousal, there is increase in upper airway muscle activity and sufficient airflow through the upper airways. And then patient again fell asleep. So this is the cycle, like a primer event. And there is two main points. It's intermittent hypoxemia, as you can see. And the other point is arousal. So with intermittent hypoxemia, we have so many physiological consequences that leading to clinical, to specific clinical feature. So we have reduced pleural pressure and increased afterload, and that in a clinical feature represents like left heart failure. If you have ectopic heart beating or vagal bradycardia, it could cause sudden death during the sleep. So intermittent hypoxemia can cause pulmonary vasoconstriction. Then we have pulmonary hypertension and right heart failure, or generalized vasoconstriction and hypertension, or at least acute CO2 retention, which clinical feature will be chronic hyperventilation. The second important thing, arousal, leads to cerebral dysfunction and loss of deep sleep and sleep fragmentation. And then we have patients with excessive daytime sleepiness, intellectual decline, personal and behavioral changes. And on the other hand, we have excessive motor activity with restless sleep. Who are the patients that are at high risk for OSA? Obese patient with body mass index more than 35, patient with congestive heart failure, atrial fibrillation, treatment with refractory hypertension, type 2 diabetes, nocturnal dysrhythmias, stroke, patient with pulmonary hypertension, a patient with high risk driving population, and patient for preoperative preparation for bariatric surgery. So for all those patients, we have to do the screening sleep study. What are the symptoms? We have day symptoms and night symptoms for obstructive sleep apnea. Day symptoms are excessive daily sleepiness, feeling of tiredness and weakness, mood disorder, reduction of concentration and working capacity, and morning headache. So more important is excessive daytime sleepiness. During the night, we have a snoring, observing stop breathing or night apneas, night dyspneas, restless sleep, esophageal reflux, dry mouth and thirst, bruxism, night sweating, and nocturia. So most important are snoring and observe stop breathing during the night. The gold standard for the diagnosis is polysomnography, that's sleep study. We have 4 types of sleep study. The first and second one with minimum 7 channels. You can see what they are including. And the first one is usually with video as well, and we provide it in a sleep lab, and the other sleep study we can provide at home. The most frequent that we are used is level 3 with 4 channels that we use for sleep screening. Most important event that we observe during the sleep studies, apnea. We have 3 types of apneas: obstructive, central, and mixed. Obstructive apnea, you can see here airflow. There is no airflow, but there is effort, so there is movement of rib cavity and abdomen. And after apnea, we have desaturation or arousal, or both. With central sleep apnea, we don't have movement, we don't have effort, as you can see that flat line as well, and the same, there is arousal and desaturation. With mixed, they're starting like central, and then we have movement of abdomen and the rib cage. So it's continuing like obstructive sleep apnea. The second entity is hypopnea, more than 30% of flow reduction and more than 3% of oxygen desaturation or arousal, lasts more than 10 seconds, and usually it's obstructive, as you can see. How we assess severity, it's we need apnea-hypopnea index. That's the number of apnea or hypopneas per 1 hour of sleep. And the mildest if it's between 55 and 15, between 15 and 30 is moderate, and more than 30 is severe. For example, we had a patient with 150 apnea-hypopnea index, so it's really severe. Diagnostic criteria are RDA more than 5, with 2 of these other criteria, like excessive daytime sleepiness, or 2 or more following criteria: nocturnal dyspnea, frequent awakenings, non-restorative sleep, tiredness during the day, impairment, concentration. So 2 of them with RDA more than 5, or excessive daytime sleepiness with RDA more than 5. RDA is a respiratory disturbance index. It's number of apnea, hypopnea, but RERA as well. RERA is respiratory event related arousal. It's the sequence of obstructive respiratory events which leads to arousal, but it doesn't mean not meeting the criteria for apnea or hypopnea. So for screening, fast screening, we use the questionnaires. The most appropriate one that we use in everyday clinical practice is Drawbacks questionnaire. That cutoff is more than 3 points if patient has snoring, tiredness, observed stop to breathing, high blood pressure, body mass index more than 35, age above 50, neck circumference more than 42, and gender male. That's the points, and we are scoring that. And if it is more than 3, then sleep study should be provided. The second questionnaire is effort sleepiness scale. It's not only for screening, it's also for follow-up that we use. What is the treatment for obstructive sleep apnea? First and gold standard is CPAP therapy. Then oral appliances, mostly mandibular advancement device, surgery. Dr. Hiba probably will talk about this, uvulopalato-pharyngoplasty, maxillofacial surgery, and bariatric as well, and hypoglosal nerve stimulation. So, but CPAP treatment, it's gold standard, and it's continuously placed ambient air, creating positive pressure in the respiratory system, preventing collapse of pharyngeal wall. It should be used at least 5 to 4 hours during the sleep, and it's safe because side effects are not significant. If there are cures, they're very mild and reversible. Oral appliances and the mandibular advancement device, they are using it with moderate and severe OSA in patients who are not tolerate CPAP well, and it should be used also more than 4 hours per day. And what is most important, that the benefits is for cardiovascular effects. There's recommended in 260 for mild and moderate also, as I said, and with patients who are not, who don't have a adequate response to CPAP treatment. Also, there is tongue retaining device, as you can see. Just reposition lower jaw and tongue and surroundings of tissue structure in that position, that upper airways are released and dilated. The surgery, bariatric surgery, has a positive effect not only on sleep, but also on metabolic consequences and comorbidities. And usually with those patients need CPAP as well. And the last one, hypoglossal nerve stimulation, that's stimulation of pharyngeal dilator muscles and their nerves. And what could be a problem, the signal is sometimes too strong, usually it's too strong, and lead to sleep fragmentation. That is side effects. We have to pay attention, especially about positional also, as they usually additional treatment. In the past, we used the tennis ball technique, but now there is neck-worn devices and positional alarm devices. It's usually start to give us vibration after 15 seconds, 10 seconds at back position. And that is the second line treatment. For pharmacological therapy is not recommended, as you can see, only modafinil for treatment of excessive daytime sleepiness despite adequate CPAP treatment. BILEVEL modes only for patients who will not tolerate high pressure on CPAP, and BILEVEL with spontaneous time mode and backup rate we can use for treatment of central apneas. And the other type of device is adaptive servo ventilation. We use with patient with change tox respiration if CPAP treatment doesn't work, and in presence of central sleep apnea during the titration, we call that complex sleep apnea. Supplement of oxygen. That is not and never first line treatment. It's only if there is overlap sleep apnea with obstructive pulmonary disease, and those patients had saturation lower than 88 during the day. So what is important, and the new approach to treatment of obstructive sleep apnea is multimodal treatment. As you can see, there is the different combination of treatment, depends of patient. We call it like personal treatment for each patient personally. If we don't treat that well, if we don't treat also, there is a lot of complications that you can see, and most of those complications are related to cardiovascular system, and Dr. Syed will talk about that. And there is memory loss, diabetes, fatigue, throatness, obesity, and impotence. So we have to treat those patients well. We have, at the end, I would like to underline that until these two most common symptoms, snoring and excessive daytime sleepiness, they're considered common, and the patients do not ask for medical attention for them. And that's why we need to actively seeking those patients and screening those patients. They will not come to doctor with some kind of asking for problem, for those problems. And as Dr. Syed mentioned at the beginning, a multidisciplinary approach and effective teamwork of pulmonologists and ENT specialists at the beginning, and neurologists, dentists, psychologists is important for adequate treatment and also cardiovascular specialist for consequences and for screening those patients, because most of those patients are coming to cardiologists at the beginning. So thank you so much for attention.
Thank you very much, Dr. Mariana, for this wonderful and a very comprehensive overview of sleep apnea. I'm sure there will be questions, so please kindly stay back for the question answer session. And also thank you for finishing dot on time.
Most
Now,
welcome.
next, I would like to invite my hospital colleague and a friend, Dr. Hibal Rifi. Dr. Hibal Rifi is a consultant rhinologist and facial plastic surgeon. She trained for a number of years in London. She obtained her FRCS in 2013. After completing her CCST, she worked as a locum consultant at St. Guy's and St. Thomas's Hospital in London before she moved to Bahrain in 2013. She currently works in Awali Hospital, but before she joined Awali Hospital, she headed the ENT department at King Hamad University Hospital here in Bahrain. She is currently the medical director at Awali Hospital. She is an examiner of European Board of ENT, and she has also published scientific papers in high-impact ENT and rhinology journals. She is Middle East representative of European and American Facial Plastic Academy. Dr. Hiba is going to talk on ENT evaluation in sleep apnea. So over to you, Dr. Hiba, whenever you're ready. The screen is yours, and welcome.
Thank you very much, Dr. Syed, for the invitation, and thank you for all of you who are joining us on a weekend evening to attend this hopefully useful webinar. I will talk to you on a surgical point of view in ENT evaluation of sleep apnea. And even though my colleague, Dr. Mirjana, had beautifully covered everything that I will concise from a surgical point of view, please forgive me if it sounds a repetition to the beautifully highlighted lecture by Dr. Mirjana. So why is ENT involved? The last slide Dr. Mirjana had demonstrated was stressing on the fact that to approach patients with obstructive sleep apnea, we need to have a multidisciplinary approach. So you need a psychiatrist, a cardiologist, a pulmonologist, a dentist, and an ENT surgeon. And that's adding to that, I would also include the anesthetists in recent days, and I will come further to that in my discussion. So who refers those patients with snoring or obstructive sleep apnea to our ENT clinic? How do they end up in our ENT clinic? They're either referred to us by the pulmonology team, so the respiratory team at the hospital, or referred to us by the GP and the tertiary or the primary care line, or the patient comes directly thinking that from a surgical point of view, we have a cure to their problem. If we go back on some anatomy and just basic anatomy to see from an ENT point of view, how do we need to evaluate those patients? They would either have obstruction in the nose, so it's either a deviated nasal septum, polyps, if they have allergy and rhinitis, or they have hypertrophy of the inferior turbinates obstructing the nasal airflow. They could have an oral pathology, so it's either large tonsils, large tongue base, oropharyngeal collapse, or even circumferential collapse. So the whole area from the oropharynx, nasopharynx, and tongue base collapses whilst the patient is snoring. And this would lead to an oral pathology compromising their sleep and leading to the obstructive sleep apnea. Or they have a congenital anomaly or congenital variation like receded chin or micrognathia, where they have a small receded chin, and for that they'll have retraction of their tongue base and oral content, and that would lead also to obstructive sleep apnea. So these are basic anatomical variation which leads to the pathology itself. What is our role as ENT surgeons for those patients? The patient classical journey, the patient will be referred to us from our colleagues, and then we need to evaluate them if there is any role for us as surgeons to interfere with their management. So we need to have a detailed history covering their daytime symptoms of daytime somnolence, what Dr. Mirjana has mentioned earlier, the daytime symptoms. So the patient classically get asked questions like, do you doze off when you're driving the car? Do you doze off at meetings, when you're watching TV at home, or when you're reading a book? These during the day. And if the answer to that is yes, 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 the patient will have symptoms of daytime sleepiness, even though they say we've had 7 or 8 hours of night sleep, but they don't feel fresh. This is an objective assessment. Subjective assessment would be through Epworth score. So again, a list of questionnaire, and we grade them according to their Epworth score as part of their history. We also have to include in the history medical morbidity, patients who are overweight, patients with diabetes, thyroid functions, underactive or overactive thyroid function, patients who have hypertension or cardiovascular diseases. This should also be covered in the history itself. And when I move into the examination for those patients, I need to do anterior rhinoscopy, which means examining the nasal cavity for all the pathologies I have covered earlier, looking for any obstruction in the nasal airflow. We need to have a detailed oral examination as well to assess the size of the tongue, the movement of the tongue, the size of the jaw, and then we perform a flexible nasal endoscopy, which is a very helpful tool in an ENT clinic. And often Dr. Mirjana sends patients, so we do just that assessment for them with a flexible nasendoscopy. And when we're doing flexible nasendoscopy, it gives us an idea what happens beyond the area of the nose and the oral cavity. So we're looking at the postnasal space, we're looking at the hypopharynx, the oropharynx, the nasopharynx, and in overall, the upper airway. And the idea is to see if there is any physical obstruction that confirm the cause of the patient apnea. We then move on to investigation, and we ask a very important question. Is there any tool to investigate this patient to give you an answer to their pathology? So what's the role of imaging? Cone beam CT scan, which is a very concise machine we have at Awali Hospital. It is a form of low radiation CT imaging to the sinuses and the nasal passages, and it confirms if the patient has any obvious nasal pathology, whether it's sinus pathology or nasosinal pathology like polyps or enlarged inferior turbinates, or in some cases tumors causing obstruction. The role of X-rays or OPG is very limited in diagnosing of peripheral obstructive sleep apnea, yet you'll find some dentists performing that, especially those with maxillofacial pathology, and that can be confirmed on the X-ray, standard X-ray. Sleep study is, as what Dr. Mirjana said, the gold standard in the diagnosis of the level of obstructive sleep apnea. And we have polysomnography, which is the gold standard, and that's the sleep study all through night, or the apnea graph tool, which I will come to in the next few slides. And finally, the sleep nasal endoscopy. And the sleep nasal endoscopy is actually introducing pathological sleep or pharmacological sleep. So the patient comes in theaters, you need to work with a very experienced anesthetist who's capable of putting the patient just in the right level of sleep. And then we perform the nasal endoscopy to see where is the level of, so the patient starts snoring and we'll see where is the snoring coming from. Then you ask your anesthetist to perform a jaw thrust. So the anesthetist will lift the jaw of the patient whilst your camera is in, and you'll be able to establish if the snoring is improved or not. It's a very useful tool. So in the next few slides, I will just cover a prospective study that I have done on the apnea graph, which is the tool in the diagnosis of obstructive sleep apnea. And it's not as efficient as a polysomnography, but it is a home study. So we want to know, is surgery has a role in obstructive sleep apnea? Very limited. And I think it's a very important message to all the ENT surgeons that there is no surgical cure for central obstructive sleep apnea or patients who have other morbidity, and surgery is never the first line. And I think ego and arrogance should not come in the way. You have to always consult your medical colleagues, as the role of surgery is very limited in patients with obstructive sleep apnea. This should be guided by the result of the sleep study. Only in peripheral apnea, so there is peripheral obstruction because a very obvious nasal deviation due to trauma or polyps, then the role of surgery is there. sorry. So we were talking about the apneograph. An apneograph is a new diagnostic tool, and it is used to micromeasure the pressure of the pressure which comes in from the airflow and the upper airway pressure. It's a catheter, which I'll show you in the next few slides. It evaluates the severity of obstructive sleep apnea, and the advantage of that, the patient can have the monitor in and go home as a home study. This is the device itself. It's a pocket-sized device, slightly larger than a mobile. It has two catheters with it. One goes in the inserted as an insertion of a nasogastric tube, and the other one is monitored through the chest. So the channels is the upper airway pressure channel and the lower airway pressure transducer. It also measures the heart rate and the pulse oximeter to measure the oxygen. And this is how the patient would be hooked into these monitors. You have to make sure that the level of the transducer is just behind the uvula when it's inserted. And the study was designed to look over 25 patients with obstructive sleep apnea. These patients all underwent sleep nasal endoscopy and had a 10-minute apneograph analysis performed. When we looked at the results of the apneograph, we looked at the level of oxygen desaturation, the level of AHI or apnea-hypopnea index, and we confirmed this or compared this to patients who had PSG or polysomnography. And the idea was to see how accurate or what is the correlation between patients who had polysomnography and apneograph itself. The negatives or the drawbacks for the study was not tolerated by 13 patients out of the 25 that we have done. But we continued to perform the study. 7 patients had catheter dislodged during their sleep because it's not convenient to have the catheter in. And 3 patients had the catheter removed themselves after 2 hours from the sleep. So the results were not included. They were not part of the 25 cases that we've had gone through the results. And the major advantage is it is a cost-effective device if you compare it to polysomnography that is performed on every patient who has sleep apnea. So the sleep apnea, and these are figures done according to the UK study that I was the primary investigator on, and we looked at the number of PSGs done in a national trust. And the sleep nasal endoscopy cost around £1,000 per patient, whilst the apneograph cost was much less than that. So it is a cost effective from that point of view. And there was a potential savings to the trust, approximately 30 or 300,000 pounds per year by shifting from apneograph to from polysomnography to an apneograph. So in conclusion, these devices are alternative to polysomnography. It gives you as good results and are cost effective. And apneograph remains a second best option to the polysomnography if that is an option available and where you are. That's it for now. So thank you very much for listening to me, and I'll be happy to take the questions at the end of the session.
Thank you very much, Dr. Hiba, for your input. And ladies and gentlemen, you can see that Dr. Hiba is a part of the multidisciplinary team, and she can be very useful member of the team for alleviating all the problems a patient may have with sleep apnea. Thank you very much, Dr. Hiba, once again. And now it's my turn. So I believe I don't need to introduce myself. I think I've done my introduction. But just let me start to share my slides. So can you see my slides, first of all? Okay. Okay, so good evening once again to everyone who has joined late. So I'm Dr. Syed Raza, and I'm going to speak on the cardiovascular effect of sleep apnea. So as you all know that sleep apnea generally affects nearly every system of our body. But my job tonight is to give you an overview as to how sleep apnea leads to cardiovascular complications. I'm going to very briefly touch upon the pathophysiology, and I would finally finish with some of the management strategies that may help us to alleviate those complications, those cardiovascular complications related to sleep apnea. As you can see here on the screen, the sleep apnea can lead to a wide variety of cardiovascular complications ranging from simple as hypertension to a catastrophic event like sudden cardiac death. In between, you have cardiac arrhythmia, coronary artery disease, stroke, pulmonary artery hypertension, and heart failure. Pathophysiology as to how sleep apnea affects or causes cardiovascular disease or cardiovascular complications is very complex. But it is down to mainly three mechanisms that you can see on the screen. One is hypoxia. Number two, there is negative intrathoracic pressure. And number three, there is arousal, which means that the patient who is trying to sleep wakes up several times subconsciously, and this leads to increased sympathetic activity. So to discuss the pathophysiology in more detail, you can see here on the screen. So the basic mechanism is hypoxia, and significant hypoxia will lead to oxidative stress, and this will cause organ dysfunction. And here we are talking about the heart, so it will lead to structural damage to the heart by severe hypoxia. Severe hypoxia in presence of either increased in the carbon dioxide or decrease in the carbon dioxide also leads to systemic inflammation, and this will in turn lead to endothelial dysfunction, meaning thereby there'll be changes inside the arteries of the heart, and there will be changes that will predispose to thrombosis in the arteries, particularly the coronary arteries, the brain arteries, and also this will also lead to vasoconstriction. Severe hypoxia in presence of hypercapnia will also lead to increase in the ventricular afterload, and this it does because it causes also changes in the pulmonary vasculature. Small blood vessels in the pulmonary circulation, they vasoconstrict, and they will lead to increase in the pulmonary arterial hypertension and increase in the right ventricular load. You have heard that patients wake up a number of times, and this is called arousal. And this is a trigger for increasing in the sympathetic activation, or there is parasympathetic withdrawal. And what it essentially does, it leads to rise in hormones, neurohormones like epinephrine, norepinephrine. These are the hormones you will know is for the fight and flight. And there is also increase in the hormone called the stress hormone or the cortisol. And in turn, this is going to lead to increase in the blood pressure and all the subsequent effects due to high blood pressure. And also it's going to cause tachycardia. Now, both of them are detrimental to heart health. In addition, during central sleep apnea, and more particularly obstructive sleep apnea, there's decrease in the intrathoracic pressure. And once there's decrease in the intrathoracic pressure, what it does, there's increase in the preload as well as the increase in the afterload to the heart. And both of them are detrimental to the heart health. It can lead to a heart failure. It also precipitates arrhythmias of different types. Hypertension is the commonest complication or effect we see due to sleep apnea. And it has been estimated that nearly half of the patients of sleep apnea, so 50% of the patients of sleep apnea will actually have high blood pressure. Now, this may go undiagnosed or undetected for years together unless somebody actually checks the blood pressure of these patients, and then it will be found that they have high blood pressure. Now, this blood pressure is a little different from the normal blood pressure we see in our clinic because these blood pressure rise, they are not very easy to treat, and generally they are resistant to medications. So like normal blood pressure, they will not require 1 or 2 medicines. Sometimes they may require 3 or 4 medicines to control the blood pressure. In addition, if I put these patients on what we call 24-hour blood pressure monitoring, now generally when we sleep, so what happens when we retire or relax? We have a tendency that our blood pressure will go down. And that's the normal phenomenon. The blood pressure usually higher during the daytime, but when we sleep, so this is called the nocturnal blood pressure, generally goes down by a few millimeters of mercury. But in sleep apnea, because the patient wakes up several times and this causes a sympathetic stimulation, the blood pressure usually does not drop during the night. And this is called nocturnal hypertension. And this is also given a term non-dippers. So dippers are those where the blood pressure falls in those patients when they sleep. And when this blood pressure does not fall, this is called non-dippers. Now, this is very commonly seen in sleep apnea patients. How about arrhythmia? Now, we do not know the exact prevalence and the pathophysiology as to how sleep apnea causes arrhythmia. But what we do know is that sleep apnea leads to mainly bradyarrhythmia. And the commonest is the sinus bradycardia. Then there may be sinus pauses, first degree AV block, second degree AV block, particularly the type 1 or Wenckebach's phenomenon that we call. It can also lead to tachyarrhythmia. Again, the commonest is the premature ventricular contractions. There may be supraventricular tachycardia, but atrial fibrillation is one of the arrhythmias, is the commonest arrhythmia we see in our clinical practice, and the prevalence or incidence of atrial fibrillation increases by 5-fold. So that is one of the arrhythmia that we should be on the lookout for, is atrial fibrillation. Rarely it can also cause non-sustained and sustained ventricular tachycardia. And when these arrhythmia occur, particularly the ventricular tachycardia, which is sustained, may progress to ventricular fibrillation, and that can be a cause for sudden cardiac death in these patients. Now, do we treat with antiarrhythmic medications in these patients? No. Generally, what is advised and what the guidelines are that you must reverse all those causes that have been related to sleep apnea itself, meaning thereby we try to, we ask the patient to lose weight or use a CPAP machine, because the antiarrhythmic treatment generally does not work, and therefore it is generally not recommended. There may be specific targeted therapy if any electrical conduction abnormality has been detected. Say a patient does go on to have electrophysiological studies, and if we find any conduction abnormality, then that patient may have a laser therapy or specific medication, but otherwise we do not use any antiarrhythmics. In the past, cardiologists used to apply atrial overdrive pacing, but it has been found that it is not helpful, and therefore it is not recommended. How about coronary artery disease and stroke? So the risk of coronary artery disease in sleep apnea increases by 30%, and the risk of stroke increases by at least 60%. So you can see the relationship of sleep apnea and the cardiovascular disease. So certainly it is quite significant. And as I mentioned earlier, the atrial fibrillation increases by 5-fold in sleep apnea. And you all know that atrial fibrillation is one of the predisposing factors for ischemic stroke. So obviously this causes ischemic stroke by more and more incidence of atrial fibrillation. It has also been observed that subarachnoid hemorrhage incidence is higher in patients with sleep apnea, and particularly in patients of younger age. Sleep apnea also predisposes to fatal as well as non-fatal MI. And it has been observed through studies that the patients of sleep apnea, they undergo more procedures like PCI or coronary artery bypass surgery. One thing we have noted, again, this is evident from studies and trials, that the cardiovascular complications, they occur early, and there's increased cardiovascular mortality in patients of sleep apnea. Sleep apnea and heart failure go hand in hand. And when I say this, I mean, if somebody has got sleep apnea, it can lead to heart failure. And if somebody has got heart failure, there's every chance or a good chance that this patient will develop sleep apnea. And in patients of heart failure, it is particularly the central sleep apnea that is a problem. And patients of heart failure, advanced heart failure, are predisposed to central sleep apnea. Patients of advanced heart failure in NYHA class 3 and 4, patients who are male and particularly who are above the age of 60, these are the group of patients who are likely to have central sleep apnea. But you will see in the bottom of the slide, the female patients of heart failure, for some unknown reason, we do not know the cause as to why they do not have sleep apnea. to that extent that the male patients or counterpart will have. So what are the factors that influence heart failure in sleep apnea? So we all know that hypertension is a common association in sleep apnea. Atrial fibrillation increases by 5-fold in sleep apnea. So this is again is a predisposing factor for heart failure. Sympathetic drive, overdrive that I mentioned earlier, increase in adrenaline, non-adrenaline, increasing the heart rate and blood pressure, they once again contribute to development of heart failure. Once there's a decrease in the intrathoracic pressure, there's an increase in the preload and afterload on the heart, and that once again will contribute to increase in the left ventricular end diastolic pressure, and this in turn will lead to impairment of the left ventricular systolic function, leading to heart failure. As I mentioned earlier, there will be changes in the pulmonary circulation or this pulmonary circulatory bed, and this will lead to increase in the pulmonary arterial hypertension, and this is going to predispose to right heart failure. We all know by now that the most catastrophic event that one can expect in sleep apnea is the sudden cardiac death. Now, once again, we do not know as to what is the exact mechanism how sleep apnea or obstructive sleep apnea can cause sudden cardiac death. But what we know is that once somebody has got obstructive sleep apnea, and if they have got the severe or the severest form of sleep apnea, this is going to increase the risk of sudden cardiac death by 300 to 400%. Now, when we are talking about the severity of sleep apnea, and as Dr. Mariana has mentioned earlier, so there are different types of sleep apnea, or there's different severity of sleep apnea that is based on the apnea and hypopnea index. Now, as you can see here on the graph, patients who have got hypoapnea index of more than 30, which means they have got this severe form of sleep apnea, the survival in these patients is not great. On the other hand, if the sleep apnea is milder, as you can see on the blue line, so the survival in these patients is much better. So here the mortality is higher, the survival is much better in the patients who have got lower AHI index. I'm not going to go through the management strategies, but what I'm trying to allude here is that what are the ways that you may help the patient of sleep apnea that will help to alleviate the cardiovascular complications. Now, weight loss is the key to the treatment here. Now, when we see patients of sleep apnea in a cardiac clinic, then our focus has got to be on the weight loss. It's not only that to relieve the symptoms and signs and the effects that the person is having due to weight gain or obesity. In addition, the person is going to have other benefit of comorbidities like diabetes, high blood pressure, cholesterol levels, and everything else that is going to be sort of improved. And that is going to play a role in decreasing the cardiovascular complications or ill effects. CPAP has been tried, and I'll discuss in my next couple of slides whether CPAP is helpful in reducing cardiovascular outcome or not. Adaptive zero ventilation was mentioned by Dr. Mariana and will be mentioned again by Lisa after my talk. And this is primarily used for central sleep apnea and mixed sleep apnea or complex sleep apnea, I should say. Now, this has been tried in one of the trials called Servo heart failure trial. And this machine was used in patients who have heart failure with reduced ejection fraction. And unfortunately, this was a negative study, meaning thereby that this machine or this gadget was not helpful. As a matter of fact, it increased the mortality or cardiovascular mortality in these patients, and therefore it is contraindicated to use in patients of heart failure with reduced ejection fraction. How about the stimulants, theophylline, acetazolamide, and amphetamine? They have been tried, particularly in sleep apnea or central sleep apnea, with some success in improving the cardiovascular mortality and giving some cardiovascular benefit. But on the other hand, these are medicines, particularly the theophylline and amphetamine, these are stimulants. So one has to be very careful in using these stimulants in cardiac patients because they may lead to a detrimental effect. Now, how does CPAP help the cardiovascular patients? So as you all know, when CPAP provides oxygen under pressure, and this is going to increase the intrathoracic pressure. And by doing so, it is going to decrease the preload as well as it's going to decrease the afterload on the heart. And decreasing the preload and afterload certainly improves the hemodynamics of the heart function. And in addition, it is also triggers a mechanism that is going to preserve the remodeling in heart. And therefore, it also reduces the effects or the consequences that would lead to arrhythmia particularly. Now, I'm just going to discuss a study and then I'm going to finish. So this is the sleep apnea cardiovascular endpoint study or the SAVE study. This is an Australian study and it included patients. This is a multi-center international double-blind randomized control trial. And these included patients mainly from China. More than half of the patients were from China. And of course, patients were recruited from Australia, New Zealand, India, Spain, Brazil. But if you see USA, I'm not sure why they took just 4 patients from USA. So this is something I fail to understand. Nevertheless, 2,700 patients were recruited initially. These were high-risk cardiovascular patients, meaning thereby they already had myocardial infarction, they had suffered angina, they had a transient ischemic attack, or they had full-blown stroke. In addition, they had moderate to severe obstructive sleep apnea. So mind you, they were not central sleep apnea, but they're obstructive sleep apnea. And then they randomized 2,500 patients out of the 2,700 into 2 arms. One to receive just the usual care, the weight loss and so on. And the other group, they were provided with CPAP, continuous positive airway pressure on top of the usual care. And then these patients were followed up on an average of 3.5 years at an interval of 1 month, 3 months, 6 months, and then 6 monthly thereafter. And straight to the results here, what you see in the blue line are the patients who received the usual care. Sorry, the red line is for the patients who received the usual care, meaning thereby they did not have any CPAP that was applied. The patients who received CPAP on top of the usual care is in the blue line. And as the time progressed for 1 year, 2 years, nothing happened. As you can see, these curves did not separate, meaning thereby there was no benefit from the CPAP. And coming to 3 years, 4 years, 5 years, there was some benefit in favor of the patients who received CPAP. But beyond that, then these lines met again. And then it's not shown here, but after that, the curve actually did not separate and the trial was stopped. So what do we conclude from this? So if you look at the hazard ratio and the p-value, it clearly shows that the benefit of using CPAP to reduce the cardiovascular mortality was not met. So it actually proves that giving CPAP to patients did not improve cardiovascular survival. So ladies and gentlemen, so I'll finish with this, that sleep apnea carries a high burden for cardiovascular complications and leads to cardiovascular adverse events. Therefore, it is vital that cardiovascular complications are recognized early and they are treated appropriately, because applying the right management strategies can lead to not only life-changing, but it can also lead to life-saving experience. So with that, I thank you very much. I will take the question and answers at the end, and let me stop sharing, and then I'll invite my colleague, Lisa.
Good evening, everyone.
Okay, Lisa, let me introduce. Good evening, Lisa, first of all. Just let me give you an introduction so that the people are aware who you are.
Yes.
Okay, so Lisa is a clinical coordinator and lab manager, as well as co-founder of American Gulf Sleep Diagnostics in Bahrain. She is board registered polysomnographic technologist. I think I said that correct. She has thank you. She has over 30 years experience in healthcare and 18 years in sleep medicine. She coordinates and manages sleep study lab, not only in Bahrain, but several sleep studies labs from various sleep medicine labs in America. Wow. And all her work are as per American Academy of Sleep Medicine standards. So she really does quite good standard work. And tonight she's going to speak on sleep study and CPAP. So whenever you're ready, Lisa, the screen is yours.
All right, good evening, everyone, and thanks for inviting me for the webinar. I think that sleep is definitely underdiagnosed, and we do have to get the awareness out there. So I will go ahead and share my screen. Let me see here. Let's see, make it full. There we go. All right, can everyone see it?
Yeah.
All right.
Go ahead.
Okay. All right. So some of the points that I will be going over will be also what you guys have, the previous doctors have mentioned in the screens. So what do we do as a sleep center look for when we're looking at a sleep study, and what does it confirm and diagnose? There's multiple different types of disorders out there other than just sleep apnea. As you can see, there's snoring, there's restless leg syndrome, there's parasomnias, there's sleep paralysis, again, sleep apnea. We have circadian rhythm disorders, REM sleep behavioral disorder, insomnia, bruxism, there's chronic fatigue syndrome, and a very underdiagnosed one is narcolepsy. Then we have our physiologies of sleep, and I'm just going to get my pointer here. Makes it a little easier. So we have awake. Most of us know when we're awake, but then we go into what we call N1 sleep, which is our light sleep, and this is when you're first falling asleep. Sometimes patients, think that they're going to sleep and they have what they feel like they're falling and they jerk. So we call that a hypnic jerk. And then we have the stage 2. This stage of sleep is where you're actually falling asleep and not aware of your surroundings. Then we have our N3 is our deep sleep, which is our restorative sleep. We definitely need that to feel refreshed in the morning. And we have our N4, which is our REM sleep, our dream sleep. So we have a lot of rapid eye movement during that, and I will show that in a slide moving forward. So for our physiology of sleep, we know that each one of these plays an essential role in maintaining your mental and your physical health. So this is a sleep study that I'm looking at when I'm reading one. This is in our lab. It's a 30-second screen. As you can see there, here is the eye movements, the right and the left eye. We have our EEG, which is our brain waves. We have chin monitoring our heart, our respiration rates, heart rates, leg movements, snore. There's the thoracic and abdominal and transducers and effort belts. We also look at the SpO2, the body position, and the pleth. So these are very detailed. I love to read this because not every patient is the same. It might seem like it is, but it's not. It's very interesting to me. With this screen here, this is obstructive sleep apnea, and again, it's been mentioned previously, but as you can see with the EEG leads, the patient is sleeping, and then the patient here stops breathing. So, and as you look back up into the EEG, you see the arousal in the brainwave. So this is repeatedly done throughout the night with this 3 to 4% DSAT. As you can see here at the bottom, it's causing the apnea, the patient's breathing normal, he stops breathing, causes the arousal with the oxygen DSAT. So this is happening periodically throughout the night. This is definitely going to cause a patient to have excessive daytime sleepiness, fatigue, cognitive impairment. They're not able to function properly throughout the day. Next. So here we have a slide where we have central sleep apnea with Cheyne-Stokes breathing. So again, when I'm reading these studies, I'm looking at this, and you can see that the central apnea with notable absence of the both airflows thoracic and abdominal, the pattern, the crescendo and decrescendo pattern of breathing. This is the, here is the chain stroke respiration. And then you have the deep breathing. You have it to be in, I don't know, let me move this up here. There we go. You have the deep breathing. It's thought to be part of an exaggerated response, but normally or slightly elevated PCO2. And then you have the high loop gain. As you can see here, it kind of comes up a little bit farther. This here is the mixed apnea. This is not as prevalent as obstructive or central, but it is there. And we don't see a lot of it, but if you know what you're looking at, you definitely can find it. So as you can see here, this one, the patient's breathing, then at the cannula and the thermistor, it starts to flatten out. But in the thoracic, you can still see there's some movement, kind of flattens out. But if you look at the abdominal, you can see that there's a little bit more effort here before the thoracic stop, before the thoracic stops. So this here is what we call the mixed. And then again, you have the desat and the oxygen level. And this one, of course, you can see that there's a little bit of paroxysm in there as well. This channel here is for the rapid eye movement for the REM sleep. As you can see, here's the left and the right eye, how we have the eyes kind of coming together back and forth. So it looks like the eye is pinching, but basically the eye is moving from side to side. So if you ever see someone sleeping and you see that the eye is moving back and forth underneath the lid, just pretty much know that they're dreaming about something. We don't know what they're dreaming yet, but we definitely know they are. So this is just a normal, another PSG study that we look at. And I'll go to the next. Again, mentioned earlier, we have our home sleep apnea test units. They are simplified breathing monitor that tracks your breathing, oxygen levels, and breathing effort while they're warm. The accuracy of these apnea test ranges widely between 68 to 91%. So the accuracy of these depends on whether you're at high risk or low risk of having sleep apnea. So the tests are definitely more significant for someone that is at a higher risk of COPD or their obesity or even their symptoms sometimes. So we definitely look to monitor if we think that a patient, when they come in for a consult, we take into consideration their BMI, their weight, the size of their neck, things like that. If we suspect that they're going to be mild or moderate or severe. And then, so we have 3 types of sleep apnea PAP therapies that are used. So our standard CPAP is just a machine that treats the apnea during delivering a stream of oxygenated air through a mask and tube. The pressurized air vents, your airways will collapse while you're, which allows you to breathe continuously. So it basically splints the airway. And most of these machines will do that, but the standard CPAP is for continuous positive airway pressure. It's not going to give any give or take. On our BILEVEL and BiPAP, you have 2 types of positive airway where you're breathing in a certain amount of air and you're breathing out. So the IPAP is, say at 18 centimeters of water pressure, you're going to breathe out against 14 to 15 centimeters of water pressure. And then this is, they also have the BiPAP ST with the backup rate. This is like the CPAP machine, but the treatment works by sending air through a tube. The same, it generally delivers 2 different pressures. As I said, you're breathing in and exhaling against 2 different. And unlike the CPAP, it's generally just a standard single pressure. So then we have the ASV, which is a device ideally suited for patients who have developed complex sleep apnea. This will treat both obstructive and central apnea events with this machine. I know there's been some studies against it, but there's also been a lot of positive results with this machine for patients that are even COPD. We've seen that it's helped even the BiPAP ST. So depending on the type of apnea that I'm reading and I'm seeing in a sleep study, when we go to do the titration in lab, we are definitely going to look at that PSG and say, okay, this patient has central sleep apnea. Most of the time, we're going to start out with CPAP. If that is not treating it, we're going to move to a bilevel ST, and if it have to, we will go to an ASV mode. So the different types of masks in the PAP machines, of course, these are just three pictures of the nasal pillow, and the full face. They are widely ranged in different types of masks and sizes and shapes. And we bring the patient in prior to the hookup. We fit them for a mask. We show them which to see what they might feel more comfortable with. Typically, we like to start out with a nasal mask or a nasal pillow. If for some reason that patient can't handle the pressure coming through and it's tending to make them open their mouth because it might be continuous positive airway pressure, we will sometimes move to the full face. We would start out trying to use a chin strap to help the patient keep their mouth closed because it's a habit you have to adjust to. This is something that, you know, some patients go home with it and they're like, I just can't do this. In the lab, we will sit with them. We will let them, you know, just sit in the room and wear the mask at no charge to them, just because we want them to desensitize against these masks at the pressure that we found out that they need within their therapy. So the pros and the cons of these masks. So you have, I don't know why this is not closing, but you have the nasal pillows, then you have the nasal, and then the full face. So the benefits of these masks are different. The ideal is to, you know, eliminate the sleep apnea. And a lot of times this does work. So more often than not. So the benefits for the nasal, it's ideal for patients that suffer from claustrophobia. As you can see in the nasal, it will give you more of a natural airflow. And then the full face is good for the mouth breathers. And then we have the benefits of the nasal, provides a better field of vision other than other types of masks, especially if someone's wearing glasses. You have a minimal air leakage. And then it's optimal for active sleepers or hairy people, meaning if someone's got a full beard, you know, wearing a nasal mask, it's touching the mustache, or full face would be touching the beard or the goatee, as we would call it. So it's not ideal for patients who have require higher pressure. Direct pressure, as I stated before, it would tend to make their mouth open or cause them nasal dryness. And then another drawback would be mouth breathers may not feel comfortable or it would feel unnatural. We also have, again, the optimal for the nasal. The use in that is for a little bit higher pressure. It suits to a wide range of facial structures and features, as I mentioned. The beards, also cranial dysformalities will play a part in how you're fitting a patient for a mask. We see that here also. And so we just try to take a mask that fits that patient the best. This drawbacks are for the nasal pillow, or I'm sorry, the nasal mask. For people with allergies or colds, shouldn't use it. Patients with medical conditions such as the deviated septum, the nasal value, and observed discomfort. And definitely, again, not for mouth breathers. So the good thing for the full face mask, again, for the mouth breathers, it's excellent. It doesn't matter if they're breathing through their nose or their mouth. If they're having nasal obstruction, It's best suited for the high pressures because you're able to go a little higher. They can breathe however they want. A lot of patients, they're like, oh, I'm not going to wear this. I look like I'm skydiving, or not skydiving, but scuba diving. But they like it at the end. And then they prefer it because some patients are claustrophobic, and then it provides a better support for restless sleepers. And then the drawbacks, of course, we all have that with anything, is the air leakage. Again, if there's a lot of facial hair, there's not getting a good seal. The dryness, if they're not getting the good seal, they get the dryness in the eyes or around their cheeks, and then it don't allow patients to put on their eyeglasses. And then we have our different types of CPAP machines. This is just some of the common ones by name. I think most people here know. And then we have, again, the standard. You have the BiPAP, the auto, and the portable. So again, the CPAPs, just giving the continuous positive airway pressure. The BiPAP is giving the IPAP and the EPAP. And then you've got the auto machines. I don't like so much to use the auto machines just because I feel that if you don't know what apnea you're treating, how does the machine know what apnea you're treating? So we always try to bring them in lab to do the titration, just because if someone is having central, it's going to be treated versus someone that's just having obstructive. And then we have our portables. A lot of people that travel like to use these. They're lightweight, they're small in size, and they also come with multiple power sources if you're traveling abroad. And then all machines come with humidification, the heated tubing, ramping, the data recording, and the transmission of the data. So someone can be basically sitting at home, they'll dial up and they'll give you their little code, and we just see, we can do a download of their report of how many apnea hypopnea indexes they might be having, or different type of issues that they could still be having once they're on it a month, 2 months, 3 months, however long. So, and that's what we do also in the lab. We'll put them on treatment. We bring them back the first month, the second, third, and then the 9th month as a follow-up. Again, as I've mentioned before, Dr. Raza, I don't charge for any of that. Also in our lab, if a patient doesn't succeed on their sleep study the first time, we bring them back at no charge, just so that we can get a diagnosis for that patient. Very patient, we make them our #1 priority, I will tell you that. So that's the machines. This is a picture, and I will kind of, since I know you guys are all at the same hospital, this is a picture of one of the rooms of my lab. We are set up like a hotel. We have a full bathroom and shower. They are handicapped accessible. We have, as you can see in the screen here, the oxygen concentrator ready at use, defibrillators, everything that we need to make sure that a patient is well taken care of. So I thank you guys for inviting me, and that is my information for the clinic. If anyone has any questions or concerns, they're more than welcome to reach out to us. That is my personal email as well, and I will be happy to answer any questions. Thank you.
Thank you very much, Lisa, for giving an insight and enlightening us on skills you have that help us to confirm the diagnosis. Yes, we have a suspicion when we have that suspicious eye, first of all, to make that diagnosis, but ultimately we rely on people like you to confirm our diagnosis and then choose the options or the best options with regards to the CPAP machines patient would suit the most. So thank you very much.
You're welcome.
All the speakers. And then we'll take a few questions. I can see here a few questions are already there in the chat box. And just let me remind all the audience, if you have any question, please type in the chat box. And if you want to speak up, please raise your hand. I will request you to unmute yourself, then you can ask the question directly to the speaker. So let me go to the first question. This one is I think it's directed to Dr. Hiba. The person is basically asking, is uvuloplasty the treatment for sleep apnea?
Thank you, Dr. Syed. The answer to that question is actually no. Uvuloplasty is never a treatment to obstructive sleep apnea, but uvuloplasty is reshaping the throat simply by shortening the uvula, removing the tonsils, and stitching the anterior to the posterior pillar. It is a mode to improve the oral airway when the patient has redundant soft palate, which is confirmed on a sleep nasal endoscopy. So if somebody has obstructive sleep apnea, the treatment is never uvulopalatoplasty. The uvulopalatoplasty will assist in improving the snoring. It will cure snoring if it's generated only from the soft palate, but with obstructive sleep apnea, uvulopalatoplasty could assist the CPAP usage only.
Thank you, Dr. Hiba. The next is a comment, not a question. I'll just read it out. I think mass education on sleep apnea is vital, as people are ignorant about snoring day sleeping. So this is something you have reverberated my or our thoughts for sure, because we have in mind to do some activities in the near future to increase the awareness, not only amongst the general public, but also the healthcare professionals. Because as you say, that sleep apnea, many people are not aware of, healthcare professionals are not aware of, and certainly these are the people who suffer in silence for not months, but years together. So thank you for that. Okay. Now there's a question, is as CPAP, sorry, that's part of the comment. And then the next question is, can you talk a little more on parasomnias? And the gentleman has given a scenario, a clinical scenario. You have a female patient, 60 years old, who is attacking her husband during sleep, choking and hitting, eye, etc. Do you also need a neurologist in your team? Or this is all a different entity? So who will answer? Can you talk a little on parasomnias? Dr. Mariana or Lisa, any of you?
صريح واحدة مصرية زوجة هندي ودها هناك بعد كيريلا زوج مسلم.
Can you please mute yourself? So parasomnias.
Okay, we are talking today about sleep apnea. The parasomnias is different part of sleep medicine, and it is a part of sleep medicine that neurologists should do. And and they're for sure they are including that part. If we have such a patient, we are just refer them to the neurologist. So this is not respiratory breathing disorder, it's something else.
Okay, so I think you have answered the second part already. Yes, the neurologist should be involved if there's parasomnias. Okay, thank you.
Of course. Yeah.
And then there's a question. What do you think about regulation of fluid inflow from the lower limbs to the throat? So honestly speaking, this question is not very clear to me. It probably means the increase in the preload. I'm not sure if the person who has asked this question, please, if you can rephrase your question. It's a little difficult to understand, to give an answer. And with that, I'll move to the next question. Is the deviation of the uvula, does the deviation of the uvula lead to sleeping problems or create headaches? So again, indirectly, it means that does the deviation of uvula cause sleep apnea?
I'll answer that, Dr. Syed, if I may.
Please.
So the deviation of the uvula itself, which means the uvula is pushed to one side, that is not a normal variation. That could either be due to a neurological deficit, so the patient has had a stroke, or had any surgery which has led to loss of nerve supply and led to the uvula being deviated to the opposite side, or if there is a pathology within a tonsil. So there is a unilateral soft palate or tonsillar pathology, which is shifting the uvula to the other side. And if that is the case, then the answer, yes, it contributes to snoring, which may lead to obstructive sleep apnea. But would it cause headaches? No, the headaches will not be related to the uvula directly, but the headaches would be related to the lack of oxygenation or lack of regular sleep and obstructive sleep apnea.
Thank you, Dr. Hiba. While we are waiting for a few more questions, while you are still on the spotlight, Dr. Hiba, let me ask you a question. Now, I'm sure you see children as well in your clinical practice. Now, do you encounter sleep apnea in younger patients? I'm sure this is again related to tonsils or adenoids. And what is the management approach in these patients?
Actually, obstructive sleep apnea in children is much more common to be peripheral than central. And these children are often referred from the pediatricians and not from the pulmonologist. And they come in with history of snoring and obstructive sleep apnea. And ideally, a parent will walk in with a video telephone recording of the sleep, and you will witness the apnea. Okay. Occasionally, you will see the child sleeping with chin up and using accessory muscles of respiration. And in severe cases, you'll see signs in the clinic of respiratory depression, whether intercostal recession or substernal notch. And for those children, the treatment is much more aggressive and it's often surgery. Now, in ideal situation, in a setup where we have inpatient pediatric cover, then we could admit those children and do a sleep study overnight. But we don't have this facility. So what we recommend and advise parents to attach a pulse oximeter. They can purchase that from any pharmacy, and they attach to the child overnight. They come in with various readings, and then the management will be surgically. Surgical management will be in a form of adenotonsillectomy or tonsillectomy alone, or adenoidectomy on its own for those children.
Thank you, Dr. Hiba. So while we are talking about children, so Lisa, in your experience, how easy or difficult it is to conduct a sleep study on children? And do you follow the same protocol for them as well?
Yes, well, in our lab, we do take children as young as a year old. I've done plenty of children, and I personally do them because I want to make sure that I'm getting all the information I need. Yeah, children, you know, there is, as Dr. Hiba said, it is different. We look at the apnea-hypopnea index differently in children than what we do in adults. So basically, if a child is having one apnea event an hour, depending on their BMI, the cranial deformalities, that sort of thing, will determine what type of AHI they're going to have. So if we see that it's 1 or above, you know, we're definitely sending to the ENTs to look at the tonsils, the adenoids, the uvula, and all of that as well. We don't just throw children on CPAP, but some of the children, you know, I say I've had them as young as 5, I think, was in America. Here, I've already gotten children sent to me, and they are using CPAP and they're doing great. But they are, you know, 14, 15-year-old boys and girls. So we do children in the lab as well. And we have all the pediatric equipment for that.
Okay. Yeah. I think there was somebody unmuted by mistake. So thank you very much for that, Lisa. The next question, I believe this is for Dr. Mariana. And the question is, some patients complain about fatigue and headaches and tiredness, even after showing perfect results with a CPAP device. So it means that the patient was diagnosed, given a CPAP, there was improvement, but this patient lingers on with the symptoms of fatigue and tiredness. So what can be the possible reasons for that?
So first of all, we have to know what is the perfect results with CPAP. So does it mean that when we do the card reading, is it apnea-hypopnea index normal or acceptable? If it is like that, then we should assess comorbidities. So usually some of comorbidities could be cause for this tiredness also, because they are usually with hypothyroidism or cardiovascular comorbidities or metabolic comorbidities, and we have to check is that well controlled. So they have to come for follow-up.
But will you look for, sometimes as we know, it can be a mixed picture. If you're treating an obstructive sleep apnea patients, will you in addition look for the central sleep apnea component, just to be sure?
But if you have apnea hypopnea index card reader, it's normal, then include also and central events. So sometimes if they are not they're without any comorbidities, we usually doing that, we are repeating polysomnography or do the titration again. So it depends of patient. It should be personal approach to treatment.
Okay, and what are the percentage that the polysomnographic tracings or the readings or the results may be not 100% accurate?
I do not understand what you want to say. What is the
accuracy?
percent
So what is the accuracy of the sleep study results?
If you're manually reading, then it's good. But if it's automatic reading, the percentage, it could be high. More than 30% could be different.
Okay, a false negative or positive.
Yeah, false negative or false positive or totally different. As you can say, sometimes they do not recognize change tox breathing and central sleep. So we have to just recheck it all the time. We never get report without reading the results.
Sure.
I think Lisa will agree with me.
Yes. And also I wanted to note too, in our clinical findings, that sometimes a patient that if they are compliant on CPAP and they have a low AHI, and they're still complaining of daytime sleepiness, fatigue and things like that, this is where, and there is no other issues that could cause them, we would do another sleep study while on CPAP. We would assess their daytime sleepiness for excessive daytime hypersomnolence or narcolepsy, because you can have both. Yes.
Okay, thank you, both of you.
Thank you.
Now, I think there is a question, perhaps we'll take this as a last question. Obesity is one of the main causes of sleep apnea. So if patient is asked to reduce weight, will sleep apnea improve? So that's, I think, quite obvious.
Yeah.
I think we're all going to agree to that one.
Sleep apnea will improve, but it doesn't mean that they don't need a CPAP treatment, even if they lose their weight. So we have one trial, clinical study with obese patient before and after bariatric surgery, but 30% of them, after surgery, even they reduce the BMI, and they have to continue to use the CPAP device anyway.
But weight loss, as it is evident, it's but difficult in patients with obstructive sleep apnea. They struggle to lose weight.
Yes, if they are using CPAP device, it will help because the metabolic part will improve and it will be much easier.
Energetic and
yes.
Sure.
More fresh to do exercise or other different lifestyle.
Thank you, Dr. Vanjana. Now, final call to the audience. If there's any burning question you still have, please type in, or if you want to unmute yourself, you can do so before I close this session. So I'll just give 30 seconds, and if there's anyone has a question, then yes, please go ahead. Okay, I see no question there. So with that, I first of all thank you all the speakers, Dr. Hiba and Dr. Mariana and Lisa, for being here. It's a Saturday, I know living apart your own personal time, family time, you are here with me in this webinar. So thank you very much for that. And I hope we'll do a similar event, perhaps live in the coming months for sure. And finally, I would like to thank the audience for staying so late. I can see there are a few audiences who have joined from all the way from India. So I can appreciate it must be quite late at night there. So thank you very much, everyone, for joining us on this webinar. So have a wonderful good evening, good night, and be safe. Thank you very much.
Thank you. Good night, everyone.
Thank you.
Thank you. Good night.
Good
Thank you.
night.
Thank you and good night, Doctor.
Thank you. Good night. Good night.